Pancreatitis is an acute or chronic inflammation of the pancreas, a vital organ responsible for producing digestive enzymes and hormones like insulin and glucagon. Inflammation of the pancreas can range from mild and self-limiting to severe and life-threatening. For nurses, understanding the pathophysiology, clinical presentation, and management of pancreatitis is essential to deliver safe, evidence-based, and person-centered care. The pancreas plays a dual role in the body. Its exocrine function involves producing digestive enzymes such as amylase, lipase, and proteases, while its endocrine function involves hormone production to regulate blood sugar levels. In pancreatitis, premature activation of digestive enzymes within the pancreas leads to autodigestion, inflammation, and systemic inflammatory response. Acute pancreatitis often has a sudden onset, and is typically reversible. The most common causes include gallstones, which block the pancreatic duct, and chronic alcohol consumption. Other causes include medications, hypertriglyceridemia, trauma, infections, and certain genetic or autoimmune conditions. Chronic pancreatitis, on the other hand, is a long-standing inflammation that leads to irreversible damage, fibrosis, and loss of pancreatic function. It is commonly caused by long-term alcohol abuse, but can also result from genetic conditions or untreated acute episodes. The pathophysiology of acute pancreatitis involves the inappropriate activation of digestive enzymes, particularly trypsinogen to trypsin, within the pancreas itself. This leads to inflammation, vascular leakage, edema, and tissue necrosis. As the inflammation worsens, it can spread to surrounding tissues and organs, leading to systemic complications such as acute respiratory distress syndrome, ARDS, renal failure, and multi-organ dysfunction. In severe cases, pancreatic pseudocysts, abscesses, or hemorrhage may occur. Clinically, acute pancreatitis presents with severe, constant epigastric pain, often radiating to the back. The pain may be worsened by eating, particularly fatty meals, and relieved by leaning forward. Patients commonly present with nausea, vomiting, fever, abdominal distension, and decreased bowel sounds. Tachycardia, hypotension, and signs of dehydration may indicate severe disease or complications, such as hypovolemic shock. On examination, patients may exhibit abdominal guarding and tenderness. In severe cases, Gray-Turner's sign, bruising on the flanks, or Cullen's sign, bruising around the umbilicus, may be present, indicating retroperitoneal hemorrhage. Diagnosis of pancreatitis is based on the presence of two of the following three criteria: 1. Characteristic abdominal pain, 2. Serum amylase and/or lipase levels greater than 3 times the upper limit of normal, and 3. Imaging findings suggestive of pancreatitis, usually via CT, ultrasound, or MRI. Nursing assessment begins with a comprehensive evaluation of the patient's pain, vital signs, hydration status, and abdominal exam. Accurate pain assessment is crucial, using standardized pain scales and considering both severity and location. Monitoring vital signs regularly is important to detect early signs of systemic involvement such as sepsis or shock. Nurses should document input and output meticulously, as fluid loss from vomiting and third spacing can lead to dehydration and electrolyte imbalance. The management of acute pancreatitis is primarily supportive. In the early phase, patients are usually kept nil by mouth, NBM, to rest the pancreas and prevent stimulation of enzyme release. Intravenous fluids are administered aggressively to maintain circulatory volume and renal perfusion. Electrolyte replacement, particularly for calcium, potassium, and magnesium, may be required. Pain relief is a top priority. Opioids, such as morphine or fentanyl, are commonly used. Nurses must assess the effectiveness of analgesia, monitor for side effects like respiratory depression, and advocate for adequate pain control. Antiemetics may be administered to manage nausea and vomiting. Nasogastric suction may be necessary for patients with persistent vomiting or gastric distension. In severe pancreatitis, early enteral feeding through a nasojejunal tube may be initiated once bowel function resumes, as it helps maintain gut integrity and reduce infection risk. Parenteral nutrition is avoided unless enteral feeding is not tolerated. Antibiotics are not routinely used in mild pancreatitis unless there is evidence of infection such as cholangitis, infected necrosis, or pneumonia. Infected pancreatic necrosis may require image-guided drainage or surgical debridement. Nurses also play a crucial role in monitoring for complications. These may include hypovolemia and shock due to third space, fluid loss, acute kidney injury from hypotension and inflammation, respiratory distress due to pleural effusion or ARDS, pancreatic pseudocysts and abscesses, hyperglycemia or hypoglycemia from impaired pancreatic endocrine function. Regular monitoring of blood glucose is essential, even in non-diabetic patients, as hyperglycemia is common in pancreatitis. Nursing care must also include skin care to prevent pressure injuries due to immobility, hygiene support, and emotional reassurance. In chronic pancreatitis, the focus shifts to managing long-term symptoms and preventing complications. Patients often experience persistent abdominal pain, weight loss, malabsorption, and steatorrhea, fatty stools. Nurses must monitor nutritional status, weight trends, and signs of vitamin deficiencies, particularly fat-soluble vitamins A, D, E, and K. Enzyme replacement therapy with pancreatic enzyme supplements, for example, pancrelipase, is often required and should be administered with meals. Chronic pain in pancreatitis can be debilitating and often requires a multidisciplinary approach. Nurses should assess pain regularly, coordinate analgesic schedules, and refer to pain management services if required. Lifestyle modification is a cornerstone of management. Nurses provide education and support for alcohol cessation and smoking cessation, both of which are major risk factors for disease progression. Psychosocial support is critical, as pancreatitis can significantly impact quality of life. Patients may experience depression, anxiety, financial stress due to frequent hospitalizations, and social isolation. Nurses should screen for mental health concerns and connect patients with counseling, support groups, and social services as needed. In the aged care setting, pancreatitis may present atypically, especially in frail older adults who may not communicate pain effectively. Nurses must look for subtle signs such as restlessness, confusion, decreased appetite, or functional decline. Multidisciplinary collaboration is essential, including general practitioners, dietitians, pharmacists, and allied health professionals. Nurses must also be familiar with advanced care planning and discuss goals of care in cases of recurrent, severe, or complicated pancreatitis, particularly in palliative contexts. Comfort care, symptom management, and family support become central in these scenarios. In terms of patient education, nurses should empower individuals with knowledge about their condition. Education includes the importance of abstaining from alcohol and smoking, medication adherence, especially enzyme replacement and pain management, signs of complications that require urgent review, such as worsening abdominal pain, fever, or vomiting, nutritional guidance, focusing on a low-fat diet and adequate hydration. Dietary modification is an important part of long-term management. Nurses should liaise with dietitians to tailor a nutritional plan that meets caloric needs while minimizing fat intake and preventing deficiencies. In some cases, vitamin supplementation may be prescribed. From a public health perspective, nurses have a role in prevention and health promotion, particularly around reducing alcohol abuse and promoting healthy lifestyles to reduce the incidence of pancreatitis and its complications. Community education campaigns, screening for alcohol dependency, and brief interventions can be powerful tools in reducing the burden of this disease. The use of technology and telehealth in managing chronic pancreatitis is growing. Nurses may engage with patients remotely to monitor symptoms, provide education, and reinforce treatment plans. Apps that help track food intake, pain episodes, and bowel movements can support self-management and enhance nurse-patient communication. In Australia, management of pancreatitis is guided by evidence-based frameworks including guidelines from the Gastroenterological Society of Australia, GSA, and the Australian and New Zealand Pancreatic Cancer Group for complex cases. Nurses are encouraged to engage in continuing professional development to remain updated with best practice guidelines and advances in care. In conclusion, pancreatitis is a complex condition that requires a holistic nursing approach. From acute assessment and stabilization to long-term support and education, nurses are at the front line of care. Understanding the pathophysiology, recognizing early signs of deterioration, providing empathetic support, and coordinating multidisciplinary care are all essential to improving outcomes. Whether in the hospital, the community, or residential aged care, nurses play a central role in restoring health and hope to individuals living with pancreatitis.